is a medical specialty involving the application of radioactive substances in the diagnosis and treatment of disease. In simple words, it is radiology done inside out, or endoradiology, because it records radiation emitted from within the body rather than the radiation that is generated by external sources like X-rays. So, SPECT and PET are the most common methods. So, role of nuclear medicine in CT diseases. In cardiac, it is myocardial perfusion imaging using SPECT or PET, and PET to look for infiltrative disorders, infective endocarditis, or aortic root abscesses. In thoracic surgery, VQ scan in pulmonary embolism and PET-CT in pulmonary or mediastinal tumor staging. So, cardiac, physiological basis of any stress test. So here on the screen, you can see two images. So the first one shows the image at rest and the second is in stress. So during rest, the flow is coronary blood flow is driven by the resistance, is driven by the pressure head at the proximal end of the system. The resistance in the system is denoted by R1, R2, and R3. So R1 represents to the large epicardial conductance vessels, and R2 represents the coronary arterioles, and R3 represents the wall tension provided by the subendocardium. At rest, the normal vessel, in the normal vessel, the vasoconstrictor resistance is present. In the setting of epicardial coronary stenosis, on the right side, the blood flow at rest can be maintained, but at the expense of lowering the coronary vasoconstrictor coronary resistance downstream, that is lowering the R2. So, with demand stress or the administration of coronary vasodilators such as dipyrimidine or adenosine, perfusion increases substantially in the area supplied by normal epicardial artery as the resistance R2 becomes minimal. However, it is blunted reserve is seen in the area supplied by the stenotic vessel because most of the vasodilator reserve is already been used to maintain flow at rest. So this forms the basis of all myocardial stress tests. Thus, heterogeneity in the flow is established based on the presence of upstream stenosis and can be imaged with a perfusion tracer as a defect in the territory supplied by the stenotic vessel. Stunned myocardium, depressed function at rest but preserved function. So as you can see in the image.
Oh, your slide didn't move.
Yes.
Oh, okay.
So following an acute ischemic episode, the renal wall motion abnormality occurs, and with restoration of coronary perfusion or coronary blood flow, there is gradual increase in the return of normal wall motion to normal. Coming to hibernating myocardium, depressed function and perfusion. So hibernating myocardium occurs due to abnormal flow due to progressive atherosclerotic narrowing and repetitive ischemia. Following restoration of coronary blood flow via revascularization, the myocardial function gradually returns to normal. Requirements for cellular viability: sufficient myocardial blood flow, cell membrane integrity, and preserved metabolic activity. Coming to myocardial perfusion imaging, also known as the thallium scan, viability scan, or stress myocardial imaging. So aim of this scan is to guide the surgeon or physician if revascularization, surgery, or percutaneous coronary intervention will be useful in improving myocardial recovery in a patient with known coronary artery disease, and also post-revascularization to assess the need for reintervention if the patient is symptomatic. Presence of viable myocardium means that revascularization will benefit the patient. Revascularization of an infarcted myocardium is of no benefit.
What is the clinical sign that you can say that this is a viable myocardium? Even before all this, when would you think that you need to do a perfusion scan or a nuclear medicine scan? If a patient has angina, that means there is some amount of viable myocardium. Okay.
Okay.
If there is a complete scarring, there will be no angina there.
Okay.
So that gives you a clue that there is some amount of viable myocardium. So you must see which all areas of the myocardium is viable and which needs grafting. Go ahead.
Okay. So indications of myocardial perfusion imaging. So in a patient with known coronary artery disease, it is useful when there are extensive hypokinetic or akinetic areas on echo, especially in the apical regions. In patients with reduced ejection fraction, ischemic cardiomyopathy, to assess the need for revascularization versus medical therapy. And in post-CABG or PCI patients who are symptomatic, MPA helps to assess the need for revascularization. So modalities of MPA. Single photon emission CT uses a gamma camera or positron emission tomography. Now, principle of SPECT MPA. After injection of the chosen radiotracer, here taking 99 system EB, the isotope is extracted from the blood by viable myocytes and is retained within the myocytes for some time. Photons are emitted from the myocardium in proportion to the magnitude of tracer uptake, in turn related to perfusion. The standard camera used in nuclear medicine cardiology studies is a gamma camera, captures the gamma ray photons and converts the information into digital data representing the magnitude of uptake and the location of emission. So how is it done? The study needs 4 hours of fasting. Patient should skip the morning dose of beta blockers or calcium channel blockers, as this would blunt the stress response. And patient is subjected to physical stress, treadmill Bruce protocol, or pharmacological stress using adenosine or dopamine. At least 80% of the target heart rate is to be achieved. So target heart rate is 220 minus age in years. Once achieved, the radiotracer dye is injected intravenously and the scan is performed. The scan takes about 5 minutes and will give the stress images. Patient is asked to rest for about 1 hour and then the dye is re-injected and rest images are taken. The entire imaging is ECG gated and the images are recorded in conjunction with cardiac cycle based on the RR interval. The radiotracer dye has no contraindications such as renal or liver failure as it spontaneously decays over time and gets excreted. So this is the gamma camera.
Why is not moving?
Yes, now. So this is the gamma camera used in SPECT. So the images, the photons emitted from the myocytes is captured by the gamma camera. So the parallel hole collimators are used because these can help in localizing the location of the emissions. Now this is called a scintillation event. Now, radiotracers used in SPECT myocardial perfusion imaging: thallium, technetium 99, thallium 201 and technetium 99. Thallium 201 is of historical use, not used nowadays because it has a longer half-life, 73 hours, and a low emitting energy, 80 kilo electron volts. Technetium 99 is presently used. It has a shorter half-life and higher emitting energy, 140 kilo electron volts. This 140 kilo electron volts is easier for detection using the gamma camera. Technetium 99 comes in 3 different preparations: technetium 99 system EB, tetraphosphamine, and T-boroxium. So T-boroxium is FDA approved but is not available for clinical use. 3D views in SPECT. There are 3 major views: short axis view and horizontal long axis and vertical long axis view. Short axis view takes the images in cross section perpendicular to the long axis of the heart. The short axis view shows the septal, anterior and lateral walls, and vertical long axis view is the second one in the image, shows the anterior apex and inferior walls. Now horizontal long axis view is the last one that shows the apex, septum and lateral wall. Now, fundamentals of interpretation. So we need to look, while interpreting a SPECT CT, we need to look for 3 things: presence of perfusion defect, location of the defect, coronary artery territory involved, and whether the defects on stress images are reversible on rest images. So this implies stress-induced myocardium, stress-induced ischemia, whether the stress perfusion defects are irreversible or fixed, often implying a myocardial infarction. So multiple studies have shown that the extent and severity of perfusion abnormality are independently associated with adverse outcomes. Assessment of perfusion defect. So for assessment of perfusion defect, the myocardium, the left ventricle is divided into, the myocardium is divided into 17 segments. So taken at 3 layers: apical, mid, and basal levels. So the numbering is done from the base to apex in counterclockwise. So basal has 6 segments numbered from the anterior to counterclockwise. Similarly in the base and similarly in the apical region. And one vertical long axis at mid level is also taken that represents the 17th segment. So the scoring system is used for a semi-quantitative visual assessment. Scoring system is used here for assessment of perfusion defects, so at stress and at rest. Score is assessed based on the number one. Score of 1 denotes normal perfusion. Number 2, score of 2 represents mild perfusion defect. Score of 3 gives moderate perfusion defect, and 4 gives severe perfusion defect or absent perfusion. So location of the defects and territories involved is based on the 17 segment model, which have already gone. Then this is the polar diagram showing the territories and segments in a single image. The basal segments are basal anterior, anteroseptal, basal infroseptal, basal inferior, and basal infrolateral and basal anterolateral. Similarly, mid-level segments are mid-anterior, mid-anteroseptal, mid-infroseptal, mid-inferior, mid-infrolateral, and mid-anterolateral. The apical segments are apical anterior, apical septal, apical inferior, and apical lateral. The 17th segment is apex. The next one is a polar plot diagram. So this is a bullseye polar plot diagram for patient with reversible defect of infrolateral wall. So the bullseye plot, blackout area and extend blackout plot. So blackout area shows the area of myocardium that falls below the normal, and the white area represents the area that has reversible ischemia on rest imaging. Reversible versus irreversible ischemia. So there are two images on the slide, as you can see. The first one shows infralateral wall infarct, and the second one is infralateral wall ischemia. So the first one, the stress image shows a myocardial the first one shows decreased perfusion and stress images in the infralateral wall in short axis view, even in the horizontal long axis and the vertical long axis. The resting image shows increased resting image is also the same. There is no increase in perfusion at rest also. Coming to the second one, where infralateral wall ischemia is there, the stress image shows decreased perfusion in the short axis, vertical long axis, and horizontal long axis, which improves at rest. So the second one clearly shows reversible ischemia. Then so the scores for interpretation of SPECT data: sum stress score, sum rest score, and sum difference score. So sum stress score is the sum of segmental scores from
light in.
Yes. So sum stress score is the sum of segmental scores from the stress images, represents the extent and severity of stress perfusion abnormality related to both ischemia and infarction. Sum rest score is the sum of 17 segmental scores from the rest images and represents the extent of infarction. Sum difference score is the difference between sum stress score and the sum rest score, which represents the stress-induced ischemia. Example and clinical interpretation. In this example, you can see the sum stress score is 21 and the sum resting score is 14 and the differential score is 7. Now, the summed differential score tells the ischemic burden of the heart. So, SDS of 0 is no ischemia, 1 to 3 is mild ischemia, and 4 to 7 is moderate ischemia, and greater than 7 is severe ischemia. Now, quantifying the size of perfusion defect based on 2018 American Society of Nuclear Cardiology and SPECT guidelines. Number of segments involved: 1 to 2 segments is small defect, 3 to 4 is medium-sized defect, and more than 5 segments involved is a large defect. Based on the number of segments, the percentage of LV myocardium affected would be 1 to 2 segments less than 10%, 3 to 4 is 10 to 20%, and greater than 5 segments involved is more than 20%. Other important signs beyond myocardial perfusion are lung uptake of tracer. Patients with lung uptake often have severe multivessel disease and exhibit elevation of pulmonary capillary wedge pressure and decreases in ejection fraction during exercise, all implying extensive myocardial ischemia. It is likely that ischemia-induced elevation in the left atrial and pulmonary pressure shows pulmonary transit of the tracer, allowing more time for extraction or translation into the interstitial spaces of the lung, accounting for this imaging sign. The second one is transient ischemic dilatation of the LV. So transient ischemic dilatation refers to an imaging pattern in which the left ventricle or left ventricular cavity appears larger on the stress images than those obtained with the patient at rest. For patients in whom the entire left ventricle appears larger during stress, the pathophysiology is probably related to extensive ischemia and prolonged post-ischemic systolic dysfunction, resulting in a dilated dysfunctional left ventricle during stress acquisition related to rest acquisition. The images show lung uptake of tracer and transient ischemic dilatation of LV. Analysis of left ventricular volumes and ejection fractions. With ECG gating of SPECT, it is possible to accurately predict the LV volumes, left ventricular and systolic and end-diastolic volume, thereby calculate the ejection fraction with accuracy compared to LV angiogram and cardiac MR. In ECG gating, the RR interval is divided into 8 equal segments, and events of the cardiac cycle are. The first few frames represent systolic events, and later frames represent the diastolic events. positron emission tomography for myocardial viability studies. So the basic principle of PET scan. So it uses coincident photon pairs to reconstruct images. So PET scan detects the opposing photons in coincidence. Types of tracers used in PET scan are for myocardial perfusion, rubidium-82 and ammonia-13 are used, and for myocardial metabolism, 18 FDG is used.
Slides are not
Advantages of
moving.
yes.
You forget to move the slides when you're talking, no?
Advantages of PET over SPECT. PET has higher spatial resolution, improved attenuation and scatter correction, and potential for quantifying regional blood flow in absolute terms. Higher sensitivity and specificity of PET, more than 95% over SPECT, 87% specificity and 73% sensitivity of 87% and specificity of 73% in detecting coronary artery disease. Interpretation of PET viability scan. Regional increased 18 FDG uptake relative to regional myocardial blood flow. So perfusion metabolism mismatch suggests myocardial viability and predicts reversibility of contractile dysfunction following revascularization. Consideration should be given to the fact that such a mismatch does not always predict complete recovery of contractile function because the scar and viable myocardium may coexist in such regions. Regionally reduced 18 FDG uptake in proportion to regionally decreased myocardial perfusion metabolism match suggests irreversibility of contractile dysfunction, i.e. absence of myocardial viability. So, this image shows triple vessel disease on PET scan. Reversible ischemic changes are noted in anteroseptal, LAD territory, circumflex territory, and also in the inferior. So the stress images show decreased perfusion. And the resting images show increased perfusion at rest. Quantifying the myocardial blood flow. So this is a polar map of myocardial tracer uptake during adenosine vasodilation in a patient with coronary artery disease. So here shows relative redistribution of tracer aspect as with SPECT studies suggests single vessel disease in the LAD territory. The green color represents relatively reduced perfusion compared to other territories. Then the B shows quantitative assessment of adenosine stimulated hyperemic myocardial blood flow reserve with ammonia and 13. PET identifies the abnormal flow result in all three vascular areas. LAD territory, circumflex, and RCA territory. Normal hyperemic myocardial blood flow is approximately 3 milliliters per minute per gram. As such, in addition, the addition of quantitative analysis of perfusion reserve suggests triple vessel disease instead of single vessel disease, suggested by the standard analysis of relative distribution of flow. Interpreting PET viability scan. So, the upper images show rubidium, and the lower images show 18 FDG uptake. So, the rubidium uptake shows the perfusion, and 18 FDG shows the metabolic activity. While assessing rubidium-82 is used. So 18 FDG uptake is enhanced relative to blood flow, suggesting a pattern of perfusion metabolism mismatch most abnormally perfused myocardial regions, indicative of viable hibernating myocardium. An exception is the anteroseptal region, which demonstrates a matched perfusion metabolism pattern indicative of non-viable scarred myocardium. Newer imaging modalities. Indium 111 labeled anti-myosin antibody, which specifically targets myosin heavy chain, has been used for the detection of necrosis associated with myocarditis and heart transplant rejection. Technetium-99 pyrophosphate imaging is used for diagnosis of cardiac amyloidosis. Then iodine-123 MIBG neurocardiac and 18 FDG metabolism cardiac imaging to guide ventricular tachycardia ablation in heart failure. This is technetium-99 pyrophosphate imaging used in cardiac management. So the top row shows sections of whole body planar, and
Like bottom row shows,
yes, the top row shows the technetium-99 top row shows the planar whole body acquisition, and the bottom row shows SPECT images. Technetium pyrophosphate. Now on the left panel, when we compare, the uptake is lower than myocardial uptake is related. There is no myocardial uptake, effectively excluding transthyretin cardiac amyloidosis. In the middle panels, uptake of myocardial uptake is equal to bone uptake. In the right, grade 3 uptake is seen myocardial uptake greater than the bone uptake. Uptake of this tracer marks the myocardial deposition of transthyretin amyloid. So the third one is suggestive of cardiac amyloidosis. cardiac prosthetic valve and LVAD related infection. Almost half of prosthetic valve endocarditis.
Slide. Don't forget to move the slide, man.
Yes. Almost half of prosthetic valve endocarditis are complicated by periannular extensions and require urgent surgical intervention. Transesophageal echo may fail to recognize this potentially fatal complication. Although ECG-gated CT angiography can improve the diagnostic accuracy in some patients, it is also a purely anatomic technique. FDG PET CT is not advocated as a first-line or confirmatory imaging study for detecting prosthetic valve endocarditis. Rather, it should be reserved for patients with clinical or microbiological suspicion of endocarditis, but negative or indeterminate transesophageal echo. The image shows periannular prosthetic valve endocarditis detected by FDG PET. Patient with bileaflet mechanical aortic prosthetic valve, placed 20 years earlier, presented with fever, blood cultures, and positive for Staph aureus. Despite high degree of clinical suspicion of endocarditis, findings on transthoracic and TEA as well were unremarkable for evidence of infection. 18 FDG PET CT fused image revealed high uptake around the aortic prosthetic heart valve near the proximal right coronary artery. Subsequent CT revealed a mycotic aneurysm beneath the RCA origin, confirmed by urgent autopsy. This is an LVAD driveline infection. So, few CT and FDG PET imaging of driveline infection with a hisplantation patient present in terms of pain, purulent discharge, and non-healing driveline site for 6 months after exit site 6 months after the implant. The driveline culture revealed coagulation negative Staph aureus and yeast. PET CT image shows intense linear FDG uptake along the driveline and percutaneous exit. Coming to the lung VQ scan. What is a VQ scan? Ventilation for scintigraphic examination of the lung. Indications of VQ scan. Diagnosis of suspected pulmonary embolism. Monitor pulmonary function following lung transplant. And provide lung function in lung cancer patients where pneumonectomy is planned. So, how chest X-ray is needed to rule out atelectasis or other causes. So, ventilation scan is performed using radio-labeled aerosols like technetium 99 DTP, or patient through a non-rebreathing mask in supine position. The microaerosol particles are small tracheobronchial tree and reflect regional ventilation. The patient is then imaged in the upright position in 3 phases: initial breath, equilibrium, and washout. The perfusion lung scan involves technetium 99 MAA microaggregated albumin administered intravenously in supine position. These MAA particles are just small enough to create large in the precapillary arterioles. At high resolution, large field of gamma large camera is used to image the lung.
Go back to the previous one.
Yes.
Okay.
Yes.
Next. Go on.
Yes. So this is a normal VQ scan and the effects of gravity.
You didn't show that slide.
So the first one is the first two images.
Slide, please.
And
your talk and your slide should coincide. Otherwise, we don't know what you're talking, where you're talking. There is no synchronization at all.
Yes. Yes. This is a normal VQ scan. The upper images show ventilation. 2 rows of images show the ventilation perfusion. So there is no VQ mismatch comparing both the images. The next slide shows mismatch VQ defects. Or here it shows the isolated right pulmonary embolus. Is ventilation but no perfusion. The second one and lower lobe and right lower lobes. Typical wedge-shaped perfusion defect. So there is a mismatch between ventilation and perfusion. So in a pulmonary embolism, ventilation is maintained, but the mismatch is quite clearly seen here as a wedge-shaped defect, perfusion defect. Acute versus chronic pulmonary. VQ scan cannot differentiate PE with a single scan. We need a repeat VQ scan after 3 months. If the perfusion defect resolves, it is an acute pulmonary embolism, and if it persists, it is to summarize. Myocardial viability assessment is crucial in the management of coronary heart failure. Next, the various methods of myocardial perfusion imaging, SPECT and PET CT. Important to know the physiological basis of stress scans and imaging is an important predictor of long long-term mortality, artery disease.
Yes,
Non-coronary artery disease uses of nuclear scans. Yes. And VQ scan and it will come across CTF cases. Thank you.
You didn't talk about PET scan in staging